Hello, my dear friends. Welcome to the today's daily dose. I am myself Dr. Rajesh Gubba. I'm a cardiologist, and I'm also the mentor for teaching general medicine in exams like NEET PG, PGI, AIIMS, and as well as JIPMA. So, as the part of today's daily dose, the clinical question is: I have a 63-year-old male came to the accident and emergency department 2 days after the discharge. Right, 2 days back he got discharged, and again he was brought to the emergency department. And why he got admitted previously 2 days back? So previously he had an uncomplicated MI where it was corrected, properly treated, then got discharged. 2 days after that, he brought to the emergency department. And what exactly are the complaints this time? This time, he complains of rapidly worsening shortness of breath over the 48 hours, but no further chest pain. Only symptom now is dyspnea, exertional dyspnea. And this time, the patient is tachypneic on examination, and even if you take the pulse rate, it is regular, but tachycardia is there, which proved to be a sinus tachycardia. And JVP was examined, the JVP was raised. And there is also pansystolic murmur on auscultation. And where exactly is the murmur? It is at the left sternal edge. That's a very, very important point. Why? I will tell you. Which of the following is the most likely diagnosis? The options are mitral incompetence, ventricular septal defect, aortic stenosis, Dressler syndrome, reinfarction. Now, this particular question is completely for discussion on the complications after myocardial infarction. So if you see the complications after myocardial infarction, the individual can develop the mechanical complications, or the individual can develop electrical complications after myocardial infarction. Now, what are the electrical complications? The individual may land up in arrhythmias, or the individual may land up in the heart block. Either of these the individual can have. Then, but what are the mechanical complications? Remember, the mechanical complications in MI completely depends upon which MI is that, right? And what are the mechanical complications? The individual can develop mitral incompetence, the individual can develop mitral valve prolapse, the individual can develop ventricular septal defect, the individual can also have the cardiac rupture. So these are all the expected complications, mechanical complications after myocardial infarction. Now, if you see in this question, I'll just summarize the clinical points. Number one, exertional dyspnea. Right? Number one, exertional dyspnea. No chest pain. So there is no chest pain, so you can rule out the MI, because usually MI will present with chest pain. But I don't say that the MI can present without chest pain also. Without chest pain also, the MI can be there. That we call it as silent MI. Right? And this silent MI usually we see in diabetic patients. Due to diabetic autonomic neuropathy, they cannot feel the pain of MI. And the other important history is the individual is tachypneic. That is not history, examination finding. So respiratory rate is increased, and even pulse rate is also increased, tachycardia. JVP is also increased, right? And there is also presence of pansystolic murmur, and the area is important, that is left sternal edge. Now, in which clinical conditions you will have this pansystolic murmur? The pansystolic murmur can be there in patients with mitral incompetence, or the pansystolic murmur can be there in patients with ventricular septal defect, and as well as even in patients with the tricuspid regurgitation. But tricuspid regurgitation to occur after MI is very rare, right? You will not have the tricuspid regurgitation as one of the complications of MI. But you take the remaining two, VSD and as well as MR. MR murmur, where is it heard? The murmur of your mitral regurgitation, it is best heard at the apex, and that will be radiating to the axilla. So your mitral incompetence is ruled out. Why? Because the murmur is not at the apex now. The murmur is at the left sternal edge. Now, what are the clinical conditions where you will have pansystolic murmur in the left sternal edge? So you will have that in patients with the ventricular septal defect. So in ventricular septal defect, you will have a pansystolic murmur in the left sternal edge, and VSD is one of the complications which can occur after the myocardial infarction. So the correct answer to this particular question here is VSD. Whereas you take aortic stenosis, the murmur what you will have is the ejection systolic murmur, right? And it is not your the pansystolic murmur. So your aortic stenosis is ruled out. Then what is your Dressler syndrome? Dressler syndrome, it is one of the late complications after myocardial infarction. Right? It is nothing but post myocardial infarction pericarditis. The individual will present with chest pain which is sharp in nature, and that is due to post myocardial infarction pericarditis. It is not because of MI there again. And how can you make out that it is a Dressler syndrome? Remember, the ESR is elevated, and these patients, they get treated, or they'll have a very good response with colchicine or high dose salicylic acid. That is how you treat that particular Dressler syndrome. And you take the fifth option, further myocardial infarction cannot be made out in this particular clinical scenario because chest pain is not there and other features of myocardial infarction are not there. So that is the reason why your fifth option is also ruled out. Then now if you see the mechanical complications and electrical complications after MI, electrical complications are tachyarrhythmias or bradyarrhythmias. Tachyarrhythmias are like ventricular tachycardia and ventricular fibrillation. Bradyarrhythmias are the heart blocks. If it is tachycardia or tachyarrhythmia and if the patient is completely unstable, then you give a DC shock. But if the patient is like clinically stable, then you can give lignocaine. Lignocaine is a drug of choice for ventricular tachycardia. But if the patient presents to you with a block, then you can put the patient on temporary pacemaker. Temporary pacemaker is the treatment of choice if the patient is coming with the heart block after MI. You take the mechanical complications. They can have left ventricular free wall rupture. Surgery is the only option. The individual can present with papillary muscle dysfunction, right? And usually the anterior wall MI, they present with the papillary muscle rupture, or even your inferior wall MI, they can also present with the papillary muscle rupture. So the option is like surgery. And even you take anterior wall MI, they can present with ventricular septal defect, right? And the option is the surgery. The other complications are the individual may present in shock or congestive heart failure where you need to treat the patient with inotropes, and if the patient is presenting with the cardiogenic shock, IABP, that is intra-aortic balloon pump, is the option for the treatment. Then post-infarction angina, then you have to increase the treatment whatever you are giving for the MI. So aggressive medical therapy, PCI or CABG. Right? So these are the mechanical and as well as the electrical complications what you can have in patients with the myocardial infarction. Right? So I hope you might have liked this particular video. Right? So please follow us on the daily dose for the daily updates. Thank you very much.